This is CCTA case number 16. The history is that of a 58-year-old man with 4 hours of chest pain approximately 3 weeks ago. Now he is totally asymptomatic but has had a change on his electrocardiogram. There are 3 phases for review. If you move the Cine control at the top, using the next button, you can change any of the individual phases. Let's begin our review by looking at the left main coronary artery. We'll put this in the crosshairs. Left main appears to be normal. Let's change the phase just again. Oh, this is much better. You can see a very normal looking left main coronary artery. Now as we move down into the left anterior descending, you're a little bit concerned there may be some non-calcified plaque in the proximal portion of this. But as you go through the individual phases, you can see that this is probably more of an artifact than actual disease. The proximal vessel appears to be normal. Further downstream also appears to be normal all the way down to the distal distribution. Let's take a look at his circumflex artery as we move down this vessel, navigating down the vessel. This also appears to be normal. Here's an obtuse marginal branch, normal, very small circumflex, likewise unremarkable. You can change phases just to see if you can get a little better view of that. This appears to be normal. Let's now go to the foot view and take a look at the right coronary artery. This vessel, at least in the proximal segment, appears to be normal. Let's rotate around. Looking a little bit further down, there's one area here of potential concern. As we focus on that and rotate about that, this actually does look like some non-calcified eccentric plaque. Change the phase to see if we can get that a little bit better. That does appear to be non-calcified plaque, but clearly non-obstructive. As we move down to the mid portion of the vessel, you can also rotate around here and see there clearly is, again, some non-calcified but non-obstructive plaque involving the mid-right coronary artery. As we proceed down the vessel, we have a little bit of an issue here. There's a cutoff, if you will, in this particular area. Let's try to see if we can follow this a little bit further as we go down in the foot view. Try to rotate around. You can see that there is actually a cutoff here at the crux. The vessel appears to be normal. This is a registration artifact. I'll have more about that in just a second to show you how to detect these kinds of things. But this vessel appears to be normal, although just proximal to that there's some non-calcified plaque. Let's now take a look at the distal right coronary. Posterior lateral branch is normal. Now let's look at the posterior descending. Here we see an abnormality. There's the posterior descending, and then there appears to be essentially a total occlusion of the vessel in its mid portion, and then there clearly is flow beyond that point. Now with CT I cannot tell antegrade from retrograde flow, but there clearly appears to be an area here of non-calcified obstructive plaque involving the mid portion of the posterior descending artery. So this is what this patient had. He had a myocardial infarction involving the distal portion of the PDA, inferior wall myocardial infarction, which was confirmed later at catheterization. But what to do with this patient? Really nothing. He does have some non-calcified plaque and clearly needs to be treated very aggressively. We can also note here as we move down moving down caudad, you can see that there is what is a large hiatal hernia actually down in the distal portion of the esophagus. Let's take a look at the three-dimensional view here to get a little better idea of what we're talking about with respect to those registration artifacts. You can see that there are some minor slab artifacts, and then particularly down at the crux of the heart you can see this disjoint. If you put the view in an anterior view, you can almost always see this kind of registration artifact because this is parallel to the tomographic images. So this is a great way to say right away, here's a problem with registration. So again, this patient has had a prior inferior wall myocardial infarction involving occlusion of the posterior descending. He needs to be aggressively treated medically, but no further interventions should be suggested at this time.